Good morning, everyone. I'll be presenting on my topic, NISTNeedle, that is needle incision subtenons anesthesia. So, to begin with, as we all know, majority of our cataract surgeries are performed under some sort of local anesthesia, maybe topical anesthesia, subtenon anesthesia, and peribulbar anesthesia. So most of the phaco procedures nowadays are performed under topical anesthesia, but there are certain disadvantages associated with it, including it does not produce akinesia, and the pain sensitivity is not reduced when there is involvement of iris or ciliary body manipulations. Other thing is peribulbar anesthesia is also other good option to provide anesthesia, but it was found to be associated with chemosis and subconjunctival hemorrhage, and there was an also associated risk for globe perforation and retrobulbar hemorrhage. Another thing is that it has a slightly tougher learning curve because since it's a blind procedure. So subtenons anesthesia is comparatively, the learning curve is less difficult than that of peribulbar anesthesia, and it can be a good alternative option, especially in phaco-emulsive processes which involve complicated surgeries like hypermature or mature cataract, in cases of posterior polar cataract, and in patients having phacodonosis following a traumatic cataract. So our problem statement was not on subtenons anesthesia, but the technique involving it, which in the conventional technique, which involves a conjunctival seizure and which is used to dissect the stenons and the conjunctival tissue. But the opening made by such blunt dissection using scissors is large, which accounts to many complications, like it can lead to chemosis, it can lead to subconjunctival hemorrhage. There is a large defect which can be a possible nidus for infection, and sometimes it's so big that you have to also apply a conjunctival suture. So we came up with this solution. So what was the basic problem is the blunt dissection provided by this conjunctival scissor had to be eliminated. So in order to reduce the existing complication associated with subtenons anesthesia and reduce the volume of anesthetic agent used and avoid blunt tenons dissection, we came up with a instrument which like lacrimal dilator, which can be used to make a point entry, and we named it as NIST. Here's a video demonstrating the work of it. As you can see, it's a Wilder's lacrimal dilator size 3, which is just used to make a punch entry into the triangular space held by the forceps. And as you can see, just a single entry, and you can see a hole over there. And it goes into the dissects the conjunctival as well as the subtenons tissue. And just we have to do is take the viscoelastic cannula into the subtenon space and inject the anesthetic drug. As you can see, injecting the drug, and kinesia is produced in this patient. So what is the advantage of this technique is that since we are avoiding the dissection, the blood vessels rupturing in this scenario is very less, which leads to less incidence of subconjunctival hemorrhage. Also, the point entry makes us possible to like localize an area which has less amount of blood vessels. Hence, we can also, all these things can basically decrease the subconjunctival hemorrhage associated with it. Also, the volume of, since the point opening just snugly fits into the lacrimal, that viscoelastic canal diameter, the amount of drug coming out is also less, due to which they have to inject less amount of drug, and it inadvertently leads to minimal rise of IOP in the situation. So NIST technique prevents the complication made by using dissection, which is a part of a conventional technique of subtenons anesthesia, while ensuring the quality of anesthesia. And the patient, the post-operative day 1 will have clean white eye, which is very aesthetically pleasant to the patient. Thank you.
Last question. Very nice innovation. My only doubt is, since you're not dissecting the subtenon space, there is a possibility that if you've not entered into the right plane, the anesthetic can go into the subconjunctival space rather than subtenon.
Yes, sir.
So has that happened in your cases? And
very rarely, sir.
How do you avoid it?
If we hold with plain forceps, if we hold the conjunctiva properly, it takes up both the conjunctival tissue as well as the subtenon tissue. And if we just make a stab entry into the tissue, and if you just hold the conjunctiva in a form of triangular space, both the tissues are dissected at the same time. But yes, there is a possibility of it going into the subconjunctival space, but what we saw, it was very less as compared to that.
But you have not documented it.
We have not made a comparative analysis, but as an observation of many patients, now we have completely shifted to this technique because of the less complications regarding.
Basically, instead of taking a small neck, you're
Yes,
doing a stab
and
through
yes,
and through.
Yes, sir. Stab and through and
So, in many ways, we give subtenons anesthesia so that there is no needle prick.
Yes, sir.
But then, isn't a stab also like a needle prick?
Yes, sir. The thing is, we don't direct the stab entry into the eye. We direct it quite
Slightly away.
parallel or maybe even opposite to the direction of the eye.
And in which quadrant you make this stab?
Inferonasal quadrant.
It's always in the inferonasal.
Inferonasal, yes, sir.
Sure. Thank you, Dr. Bhajan.
Thank you, sir.
Thank you.